Now, before we get started here, I do want to give a very nice and proper introduction for Lisa. Dr. Desrochers is a certified instructor for CranioSacral Therapy 1, CranioSacral Therapy 2, and clinical application, and is honored to have the opportunity to guide and instruct fabulous people in fascinating locations all over the world during her 19 years teaching for the Upledger Institute International. She earned a bachelor, master, and doctorate degrees in physical therapy, as well as national certified in athletic training, and has decades of experience treating a variety of patient types. During her career, she has served as an assistant professor at LaSalle College, director of physical therapy services at Sports Medicine Boston, and athletic trainer for the Professional Men's Tennis Tour. Additionally, she served as a consultant to the Boston Celtics team physician. She currently resides and practices in California. Thank you very much again, Lisa, for being here with us for this segment, and I'm going to hand it over to you.
Excellent. So I think I unmuted. Can everybody hear me? Yes. Excellent. All right. So welcome to everybody. And I'm going to try to keep this short and sweet tonight. I know there's been some segments that have gone fairly long, so I want to touch on the basics here, and then give you maybe some good skills to be able to take back to your own athletic situations, whether it be as working with patients or on yourselves. If you're here to, if you're not a craniosacral therapist and you're here to learn some new skills. So I'm going to go ahead and get my screen up. And I want to start just by paying homage to the reason that I and most of the rest of us are here. Dr. Upledger, we lost him, gosh, over a decade ago now, and miss him dearly. But this is a quote from just the CranioSacral 1 book that any of you have taken CranioSacral 1, and of course, 100% absolutely did your prerequisite reading. He talks about muscles and connective tissues external to the craniosacral system can have a deleterious effect on that system. This is a presentation on acute injury, and just know that issues external to the craniosacral system can actually have an effect on the entire body. And part of that is because they are potentially going to affect the craniosacral system, which includes your central nervous system. So we're going to talk about ways of maybe providing an optimal environment for the body to do its own healing and not create a lot of residual problems for the system that could therefore then create problems down the road that are bigger than anybody might ever expect from a sprained ankle. So, what we hope to accomplish tonight then is just to briefly explore the physiology of injury and look at the way the body heals from acute injury, learn the effects of craniosacral therapy on the inflammatory cascade, which is the process by which the body does heal acute injury, discover how craniosacral therapy can optimize tissue reorganization and healing. So we'll talk about the reasons why that is important and ways that we can maybe facilitate that process. And then I hope to leave you all with some gentle structural and energetic techniques that you can use to facilitate self-correction and healing in your patients or in yourself, if you have your own acute injury that might come up in your weekend warrior activities. So just briefly, starting out with this slide, I'm not going to spend a lot of time here, but just to give people a sense of what we're talking about. You know, we all want to stay in shape and in good health, and right. And so going to the gym or participating in our athletics is oftentimes part of that program. But just be aware that there can be significant numbers of injuries that happen, like I said, with our weekend warrior activities. And so Some of the statistics I found, approximately 1/3 of childhood injuries are sports related. So it's something to know. They estimate that at about 3.5 million children a year injured in some sort of sports or athletics or recreational sorts of activities. So things like skateboarding, bicycling, or in their organized sports as well. Approximately 54% of high school athletes report being injured. That's more than half. That's a lot of people. Now, not all of those required medical attention. Sometimes we're talking about just sprains and minor injuries, but still, no, that's a lot of people. And then National Safety Commission reports that 3.2 million ER visits a year in 2021 were due to sports and recreational injuries. So again, we're talking about significant numbers of people requiring actual medical attention, going to the ER. And so I just have the sources cited down here where I got that information. So just in terms of patients that may be coming into your clinic, clients may be coming in, or even yourself or family and friends, I'm sure you know somebody over even the last year that has been injured somehow in some sort of recreation or athletic activity. So acute injury. We're going to talk about acute injury, and we're focusing on acute injury, but I am going to mention that, and I'm going to mention on this slide, as a matter of fact, that the techniques that we're going to talk about can be applied to chronic issues as well. So just know that, but we're going to specifically focus here on acute injury since that's what this segment is. So types of acute athletic injury, concussion, that's a pretty serious one. We know it happens a lot. We know there's been a lot of publicity around this in relation to the NFL and football related concussion. I'm not going to spend a lot of time on that here, but just know that one of our fabulous instructors, Marianne Cisco, has developed a course on concussion. So if you are one of these folks viewing right now that has started your craniosacral therapy journey, I believe the prerequisite for that class is SCR1. And also, I just found out that she's going to be doing the next In Touch sometime probably end of June. So in the next 6 weeks or so, you'll have the opportunity to log on here and hear what she has to say about concussion. So that would be a great opportunity. I'm not going to spend a lot of time on that, but we will touch on that here in just a minute. Spinal injury, another fairly significant athletic injury that can happen. I'm not going to spend a lot of time here. There can be a lot of mechanisms to spinal injury and lots of gradations of severity of spinal injuries, all the way from just a kind of a little bit of a sprain in one of the, say, synovial joints, the facet joints, all the way to a spinal cord injury. And so lots of different kind of gradations of severity of injury there. Fractures. So we'll touch on fractures. But fractures, most people know, is just a broken bone, which can happen and does happen frequently in sports-related injuries. Sprains and dislocations. So by definition, a sprain is an injury to the ligaments or capsule of a joint. So this is a joint injury. Now, many people use sprain and strain interchangeably, but just know that there is a difference. Sprain, like I said, is typically an injury to a joint, versus a strain, which is going to be an injury to the muscles or the tendons that attach those muscles to the bones. So there is a difference, sprains and strains. And those are our more acute injuries. Now, sometimes differentiating between a fracture, sprain, or strain, especially in the moment on the field, is difficult. But just know that we're going to treat many of them we're going to treat very similarly. So sprains and strains for sure. And fractures, again, depending on where they are in the severity. So we're going to talk about that here in a second. Now, overuse, cumulative traumas also are very common athletic injuries, but technically they're chronic injuries because it's something that happens over time because of repetition. So we're going to touch on that as well, even though this is technically our acute presentation, because our treatment is going to be typically pretty much the same from a craniosacral standpoint. So acute versus chronic injury, we just touched on this. Acute injury, sudden, often overwhelming injury, results from some kind of physical trauma. And we'll talk about what those causes can be. Chronic injury results from, like I said, more overuse and develops gradually over time. So causes of acute injury, pivots. So somebody's running and they go to cut and their foot catches in the grass and their knee twists, right? So those sorts of things. I actually tore my ACL dismounting the balance beam in gymnastics, doing a rotation, flipping rotation, and landed a little off balance on one leg, still rotating, boom, ACL gone. So those sorts of issues happen frequently. Falls, upper extremity injuries often happen as a result of falling on an outstretched arm or onto a shoulder, elbow, those sorts of issues, as well as collisions. And we know in football, again, sprains, strains. We had somebody actually die on the field towards the end of the season, and they had to revive them from a collision, right? So all kinds of issues that can happen because of collision. So obviously this poor bicyclist, definitely a fall, possibly a collision, we don't know, but those sorts of injuries are going to be more acute versus chronic injury, which is your overuse or repetition. So things like our tennis elbows, carpal tunnel syndrome, those are all our more chronic sorts of athletic injuries. So just to touch on sprains, strains, which is what we're going to be looking at. Remember that we talked about sprains and strains being slightly different. And the sprain was to the joint versus the sprain was to the joint versus I'm trying to get my pointer up here. There we go. Versus the strains, which are going to be to the muscle. So this is looking at a posterior aspect of an upper extremity, and just getting a look at some of the muscles here, things that we know, right? The deltoid, you can see the rotator cuff muscles threading up underneath that deltoid muscle. We know they attach onto the greater and lesser tubercles of the humerus there. We have the triceps muscles coming down and attaching right onto the elbow. We have all of the posterior extensor muscles of the fingers and the wrist running through that forearm. You can see a little bit of the intrinsics here in the hands. Any of those are susceptible to injury in athletics. It depends on what the athletic activity is that we're involved in and the mechanism of the injury. Also looking at the joints and just a couple of examples, obviously. We got a shoulder where we have the acromioclavicular joint, right, between the clavicle and where that articulates with the acromion of the scapula. So we can end up with sprains, dislocations here. We can end up with dislocations or sprains of the glenohumeral joints as well. So just to kind of give you a flavor of what we're looking at here. And then at the elbow, this has all the soft tissue stripped away except for the articular cartilage. But this is actually showing us the ligamentous structures at an elbow. And imagine very similar ligamentous structures running across the shoulder joint in the joint capsule. In the shoulder joints, in the wrist, and even in the elbow to some degree, many of our ligaments are actually just thickened areas of the joint capsule. So when you tear a ligament, it's not unusual that you've also torn into the joint capsule and damaged the joint capsule as well. So those would all be considered sprains. Lower extremity, once again, just giving us a quick kind of flavor of what we're dealing with here. This shows us a lot of the different muscles in the lower extremity. So quadriceps, hamstrings, you can see the attachments onto the bony prominences, right, of the different bones, right? We come down here and the gastrocsoleus complex all attaches onto the calcaneus. So we see those Achilles tears, right, as part of athletic injuries. We can also oftentimes see issues with the ligaments, right? So medial or lateral collateral strains. We have meniscus tears. The meniscus is the fibrocartilage, little C-shaped fibrocartilages on both the medial and the lateral aspect of the knee. So again, a twisting sort of injury. They call the terrible triad, right? Where with a twisting injury, ACL, medial meniscus, and medial collateral ligament. This is showing us the lateral collateral, but on the other side of the knee, we have the medial collateral ligament. And so the terrible triad, really common in a twisting sort of injury to tear all three. So just to give you, again, just kind of a flavor of what we're looking at, we're not going to get into great detail on each of these ligaments or joints. But here looking at a kind of an interesting cross-sectional sagittal cross-section of the foot, and you can see all of the toe joints, right? And then we have the tarsal, phalangeal, we have the muscles, the intrinsic muscles that move some of the toes. We have the big toe flexors that come from actually up on the calf, but then you can see all of the little joints between all the tarsal bones here, the talar dome, some of the ligamentous structures. So it's giving you, again, just a sense of the many different ways we can injure ourselves. Any of these joints can be sprained, any of these muscles can be strained. And so those would all be really common as far as athletic injuries. Okay, so no matter what it is, and again, we're focusing here on sprains and strains for the purposes of this presentation, no matter what it is, sprain, strain, or the combinations thereof, which can definitely happen, first response of the body is to swell. That kind of leads us into the inflammatory cascade. So this is all the first stages of healing. We think oftentimes of swelling and inflammation as being bad things, but they really are necessary for us to heal. We cannot heal without them. Repair then is the next step, and we'll talk about more specifically about what this all looks like here in just a second. And then finally, tissue remodeling. So the body is amazing, right? It's going to self-correct. Anytime it can, it's going to figure out how to fix itself. And so this is the whole process of essentially fixing itself, right? Self-correcting. We're going to eventually go from an injury where we have a torn or damaged tissue, right, through this whole process to get to a stage where hopefully we have something resembling a quote unquote normal tissue, okay, or as close to how it started before the injury as possible. So what that looks like then, swelling. Right? Many of us may have had a sprain, a strain, sprained our ankle, rolled over, you know, playing a sport, or even just stepping off a curb, right? Those silly things that happen. So swelling is our first stage of healing. And it really is what's initiating the inflammatory cascade. So we have damaged cells right now that we've torn, say, a ligament, or we've torn a muscle, or overstretched a muscle, we've torn fascial fibers, we've done something to damage this tissue in this athletic injury. Those damaged cells are going to release chemicals into our system or into that area specifically to initiate that inflammatory cascade. Those are things like histamine, bradykinin, prostaglandins, and those chemicals are all going to increase the vascular permeability. So basically, they're going to increase the ability of cells and fluid to cross through from the vascular system, right? In the veins in the system, the arteries in the system, really, capillaries, and into the tissues. And so basically, that provides an influx of tissue into an injured joint, right? So that the chemicals that are released when those cells are damaged, the chemicals that are released are going to increase the vascular permeability. So that opens up now the area for an influx of fluid from the bloodstream. And that influx of fluid essentially splints that joint, right? Now we have an internal splint. So think of it as if you had a balloon, right? And if I have a balloon and it's empty, I can bend it and twist it and tie it in a knot, right? I can do anything I want with it. Once I've blown it up, right, and there's tension on the tissues, I no longer can bend that balloon and move it the same way. So what this is doing is essentially filling up a water balloon, right, inside your joint. And so in doing so, you can no longer move it. And so that swelling creates a natural splinting or a natural protection of the joint because the body understands there's been an injury. Now it's doing what it can to protect it. So in addition to the fluid now that flows into those tissues, we also have leukocyte chemotaxis. Basically, what this means is that we have white blood cells, leukocytes, that are also permeating through the membrane along with that fluid influx. They have several purposes. So imagine a scenario where somehow at the time of the injury, there was also a laceration, something that happened, or maybe in a worst case scenario, we have like a comminuted fracture that has the bony, fragment has maybe pierced through the skin. So now we have bacteria from the outside world trying to work its way into our system. So part of what the leukocytes are going to do is they're in there and they're checking out and they're saying, what's in here that doesn't belong in here? And they're going to take care of that, right? So we have this influx of those leukocytes that are going to help to make sure that we're minimizing any risk of infection in that area. But then as the body begins to heal, now we have this damaged tissue, which essentially is now going to die, right? Because it's been torn, it's had a disruption in its vascularity, right? So it's not getting the blood flow. So eventually that tissue dies. So now I've essentially got debris as my body is beginning to try to heal this. I've got debris in there. I've got this dead tissue in there that doesn't belong. And so the phagocytosis starts. So this is all part of that chemotaxis. Initially, essentially, it's neutrophils that come into the area, but then eventually within a day or so, I also have monocytes, which are going to be predominantly responsible for starting to really clean up this debris. So that's initially what happens. As I have this influx of fluid, I also am attracting these white blood cells into this area. So that's going to begin this whole process of healing. Now, part of what happens during that phase is that fibroblasts begin to migrate into the damaged area, and they're going to stimulate production of collagen. So collagen is needed now to patch up whatever hole there is. So I've got this hole in the tissue, I've torn tissue, my body needs to patch that hole up so I'm not continuing to bleed, and that I have, again, eventually more normal stabilization of that joint so that I can continue to function. So the fibroblasts are stimulated then to migrate to the area and begin to form collagen to fix or patch up the hole. So this is all part of the process of healing an injury. So now I move into the repair phase. So once I've laid down that matrix of collagen to kind of hold things together and patch up that hole, that's not normal tissue, right? That's just collagen. That's essentially just protein. That's just holding me together. I want to, ideally, my body wants to form normal tissue again. I want a normal, or quote unquote normal, normal is all relative, but a reasonably normal looking ligamentous structure, capsular structure of that joint so that it can continue to function in the manner that it is supposed to function. So little by little, what happens is healthy cells migrate from the surrounding tissues. Say in the case of a strain, a muscle tear, right? I'll have that collagen matrix that lays down first through the muscle, but then the muscle fibers begin to, right, infiltrate into the area. And so as those healthy cells begin to migrate into that collagen matrix, that's when I begin to have what's going to start to look like a more normal tissue structure in regards to how it started before the injury. That can take several weeks. We typically talk about 4 to 6 weeks before people should even begin to go back to running after, say, an ankle sprain, because that's how long it's going to take the body to create the collagen network and begin to lay down some more normal cells in that area so that there's enough stability that they're not really prone to re-injuring or creating a chronic inflammation problem by continuing to aggravate a healing tissue. And then the final stage we talked about is remodeling. So this is where we do encourage people to begin to weight bear. If it's, say, an ankle sprain, a knee injury, we encourage them to begin to gradually work their way back into normal activities, starting very light, working their way into more vigorous activities over a course of several weeks or months. And it's the strain across that tissue. So it's the normal use of that body part, that joint or that limb, that's going to over time kind of reorient those collagen fibers and create what is a more optimal structure. So therefore, we should have a more optimal function of that area. So that's kind of the normal steps in our healing process, right? So if you have maybe taken cranial one from me, you might have seen something very similar to this. And this is essentially our path of dysfunction. So in a normal world, it should go through all of those steps, and we should end up right through that remodeling step with what is hopefully an optimally structured and therefore optimally functioning tissue. But that's not always the way it works. We don't always live in a perfect world. So what happens is, because of whatever trauma that was, we trigger this whole inflammatory cascade. We talked about how that's going to then bring fibrous tissue into the area. Those fibroblasts are begin to fill in the hole with collagen. We hopefully remodel everything, right? So everything is looking peachy and keen, but sometimes, oftentimes, that doesn't necessarily happen. And so we end up with what is a change in the tissue structure. And that can then create issue with the function and the way that that tissue is going to function. So at that point, our body has two options. The first option is it's going to compensate around that restriction. And our bodies are pretty amazing at doing that. But if our body can't compensate around it, we're going to end up with a restriction. And that restriction can create symptoms. If you have been, again, in my Cranial 1 class, you may have heard me talk about not chasing symptoms. So we really intend to evaluate the system as a whole and to not assume where we're going to find what the body is asking for us to treat. We do a whole body evaluation. We're going to follow the body. We're going to treat what we find. That said, in the case of an acute injury, it's not necessarily a bad idea to maybe do some local treatment where somebody has had a very recent injury. There's some swelling. There's the whole remodeling process that is trying to take place, just to help to optimize that whole process. So immediate treatment. So this is our immediate first aid, essentially, when these things happen. If we are present and somebody has had a concussion, we definitely want to seek medical attention. They're going to need some more medical attention than we're able to provide as craniosacral therapists in that moment. So we want to send them to the ER. We want to make sure that they get all of their testing done through that whole concussion protocol. And then once they're medically stable, once we know that everything is fairly copacetic, then we can certainly begin to treat them. And like I said, you'll hear some fabulous tips on how to do that from Marianne next month. Spine injuries. Again, just basic first aid in that moment. We never want to move somebody with a suspected spinal injury, neck, back, unless it's absolutely necessary because of an unsafe situation. And if you do need to move them in that circumstance, you want to try to keep them as mobile as possible as you're relocating them to a safer area. And then obviously we're going to seek medical attention. So that would be a 911 situation as well, if it was a significant spinal injury, especially with any suspicion of spinal cord involvement. Fractures, depending on the severity and the location of the fracture, we may or may not need to rush them off to the hospital. Some fractures are definitely more significant than others. So a femur fracture, say, where there's a risk of femoral artery involvement and potential bleeding, and we can bleed out through a femoral artery very quickly, we would need to be calling 911, getting direct pressure on that, and doing what we could to stave off any bleeding. In other instances, we definitely want to immobilize, definitely seek medical attention. Some are just more emergent than others. So it would just depend on the situation. A wrist fracture is going to be an entirely different animal than, say, a femur fracture. Sprains and strains, that's what we're talking about right now. And basically our first aid for that is the many iterations of ice compression and elevation. Some people will add the R, rest, ice compression, elevation. Some people like the price, right, which is protection or splinting, rest, ice, compression, elevation. And I'm sure there's other iterations you may have heard of, but that's our immediate treatment. So we're going to ice. By icing, we actually vasoconstrict. We decrease the amount of fluid influx into that injured area. By decreasing the amount of swelling, we may also decrease the amount of inflammatory processing that happens in that structure following that injury. And like I said, that the inflammation is necessary, but sometimes our bodies do overdo it a little bit. So if we can minimize that, then we can get people back to hopefully a more relatively normal function more quickly. That's the reason there's athletic trainers on every professional athletic field, because if they can immediately, within minutes of an injury, ice, compress, elevate, and possibly splint if necessary, those people we know statistically are going to be back on the field a lot faster. And when you're paying $3.5 million for a 3-year contract, you want your athlete back on the field, right? So we know that this is going to help to facilitate decreasing that inflammatory response, keeping it to a more reasonable level, and getting people back to their activities quicker. So where does craniosacral therapy come in? There are some premises that we talk about that guide our practice. They came from one of the pioneers of the work, Dr. Still. And the first is that the body is a unit, which makes sense to us. But again, we practice in a very reductionistic model in North America and in most places. So we don't always look at the body as a unit, but in craniosacral therapy, we always do. We know that structure and function are interrelated. I mean, that's just basic common sense, right? So I put together the way that I need to be to function and do the things I need to do. And if I have any sort of disruption in the structure, that's going to affect the function. So we know that they're interrelated and that the body is homeostatic, meaning we are always trying to self-correct. We're doing everything in our power to self-correct. So Dr. Upledger talked about that every treatment protocol should be dictated by the wisdom of the patient's own body. He was a visionary. I may or may not have mentioned on that first slide, he was a visionary, and he recognized that with all of our technology, modern medicine will never know more about what needs to happen in the body than the body knows, right? The inner wisdom of the body knows what needs to happen. And so we really want to facilitate that process, that self-healing process. So our paradigm, just really briefly here, craniosacral therapy is a gentle, non-invasive manual treatment approach that works with the natural self-correcting mechanisms of the body. The therapist acts as a facilitator to support that person's self-empowerment and their healing process. So we're not doing to, we're just there to help to facilitate and support whatever the process is that they're already trying to go through. And that the goal of craniosacral therapy is to help the person to restore and optimize the functional operation of the body. So basically, the body is trying to get back to how it was, and we're just there to help to facilitate that to happen. So obviously, in the case of an athletic injury, there is potentially going to be some issues with structure affecting function, and the body is trying to do everything it can to heal and self-correct, and we're just there to help to facilitate that process along. So craniosacral therapy can help by improving fluid flow. Now, we talked about that huge fluid influx into a joint, right? And the body is going to try to help to, over time, reabsorb that. It's doing its very best. But craniosacral therapy can help to improve blood flow in and out of the area, but also lymphatic flow, which is huge because it's lymphatics, right? The lymphatics that are going to pick up all of that interstitial fluid that's out there that doesn't necessarily belong. And we don't want people to get into a chronic inflammatory sort of situation. So we're going to talk about ways that we can do this. Also, optimizing neural input to the area. So we talk about one of the techniques that we're going to go over here in just a minute is a technique that's going to help to balance the autonomic nervous system. Sympathetic tone. So anytime there's an injury, that can increase sympathetic tone. Physical stress, emotional stress, all of those things can increase sympathetic tone, and we lose the balance between the parasympathetics and the sympathetics, which is not an optimal situation for healing. Knowing also that that autonomic nervous system does have a significant input into endocrine function, metabolic function. So all of those things can be impacted if we have increased in sympathetic tone in an area. Facilitating energetic reorganization. So I'm going to talk more specifically about what I mean by that, but just again, allowing the body to help to kind of reorganize disorganized energy will help to provide a better process or a better environment for them to go through their healing process. So as I say then, which in turn optimizes tissue repair and remodeling by allowing the body to have the best opportunity, right, to be able to go through those processes in an environment that's supportive of that process. So the craniosacral rhythm, I want to take just a few minutes to talk about the rhythm, and then we're going to have an opportunity to try palpating it on ourselves. For those of you who are not cranial therapists, this might be a new thing. And for those of you who have done it several times, just another opportunity to practice. So craniosacral rhythm is one of many rhythms in the body, and it is a way in which the inner wisdom can communicate with the therapist the body's state of well-being. So we can lay our hands on different areas of the body. We can get information from the body as to how things are there. Are there restrictions? Are there something that's creating or dampening down the ability of the body to go through its normal rhythm? That would indicate we have a local restriction. Now, in this case, where I have somebody who I watched them injure themselves, or they come to me very shortly after the injury, they're still swollen, they're still bruising, right? It's pretty obvious what happened, and we can certainly do that. But as we are going to practice here, I'm just going to take maybe a quick 2 or 3 minutes to hopefully have us be able to practice palpating cranial rhythms. Since we're focusing on joints, we're going to talk about the extremities. And classically, we have an internal-external rotation pattern at the extremities. We're talking about a very subtle motion. We can try this on our thighs if you want. On your arms, you can as well, but you may be holding more tension in your hands if you're trying to do it on your arms. If you can just softly lay your hands on your thighs, that might be the softest place. Because how we're going to palpate it is with a very light touch, very soft hands. It's the proprioceptors in your hands and your arms that allow you to feel motion that's happening under your hands. So if you're holding a lot of tension, your hands are stiff and you have them on the body, you're not going to feel anything. So soft hands, and then you just want to set your intention and meld. So we're going to take just a minute or two here. I'm going to let you take a deep breath, get yourself really relaxed, soften your hands. And see what you notice there. Do you notice any internal rotation, external rotation at those thighs? Remember that it's very subtle. You want to be very soft and you want your touch light. So ideally, you don't even want to rest the whole weight of your arm on your thigh if you can help it. So by palpating the cranial rhythm through the system, that can begin to show you where there are issues within that system. And that is our whole body evaluation tool. We're going to get into it for those of you who maybe are thinking of jumping into Cranial 1 in a lot more detail in a Cranial 1 class, first day, first thing. So we spent a lot of time there, but just know that everything is moving with that cranial rhythm. And it is one way that we can get a sense in the body of what's functioning the way that it should be, maybe what's not. One of our treatments then is going to be a still point induction. And this is to assist the body in balancing the autonomic nervous system. I talked about optimizing neural input into a healing area as helping to facilitate healing. And so still point is one of the things that we can do that can help the body to get to that homeostatic place where it can really make a lot of its own corrections. So when we're gonna, we can practice this as well, but still point induction can be done anywhere in the body. People talk about direct still point induction. That would be over the site of an injury, and that's fine as long as it's comfortable to have your hands there, or for them to have your hands there. Or you can do it more indirectly, someplace away from an injury if it's not comfortable for them to have your hands there. But basically what we're doing is gradually inducing a stillness in the cranial rhythm. So we follow the cranial rhythm, and we're going to follow it to the end range, and we're just going to hold it there and not let it move. And over a few seconds, maybe a minute, as we hold it, it may struggle to try to continue to move, but eventually the cranial rhythm will stop. The still point is a great homeostatic place for the body. So again, that really, part of that happens because we are helping to decrease that sympathetic tone in somebody who may have an acute injury, and help to facilitate them into a place where they can do a lot of their own self-healing, kind of down out of that sympathetic place that they may have gotten stuck at the time of the injury. Direction of the energy is another technique. And so we are going to practice all of these here in just a minute. But what this is going to do is it's going to facilitate the dissipation of intrinsic energy. So sometimes in the course of an athletic injury, either a fall, right, or a collision with somebody, there may be extrinsic energy. That's energy that doesn't belong in our system. It's from the outside world, and it ends up transferring into our bodies at the time of trauma. So ground force, that's an energy coming up, right? If we fall on our backside, that ground energy transfers up into our system. Or if we are involved in a collision, just think about football, right? Where you're coming at each other, and that collision can create that intrinsic energy in your system. It doesn't belong in your system. And so direction of energy can help to facilitate release of that extrinsic energy. Additionally, we can have our own body energies that do belong there that end up a little bit chaotic, or what we call entropic. And so direction of energy can facilitate reorganization of that kind of chaotic entropic energy that's related to that injury. Also, because of all of that, provides, again, that optimal environment for healing and self-correction. And know that direction of energy can be used all by itself, but oftentimes we do use it in combination with our structural techniques. So we're going to do a self exercise here in just a minute, where we're combining direction of energy in with our diaphragm techniques. To know how to use energy, basically, just know that kind of grounding, direction of energy is all about grounding and getting ourselves really grounded and really present. So whatever grounding exercise helps you to feel really present in your own system, that can be helpful. For me, I feel the weight of my sit bones, which is getting easier every day as I gain weight. Or some people like to picture roots from their feet down into the earth. I like to do a little bit of a breathing exercise where I just trace the path of the air all the way to the bottom of my lungs, and then trace it back out. So I feel it as it moves down into my lungs and back out. I become aware of any sensations in my body, and that really helps keeping me grounded in my own system. Finding neutral with our own energy, and that's really just an awareness. So we want to be aware of what we're doing with our own energy and really try to find that neutral place with our own energy. And then we're just melding with the system and offering energy from whatever outside universal energy source that's available to us, as the inner wisdom indicates. So we're laying our hands on, checking in with that inner wisdom, offering energy in or out, depending on what it's asking for. And this can help to give them a conduit out of their system for any chaotic or disorganized or extrinsic energy that doesn't belong in there, as well as helping to facilitate them reorganizing anything that needs to reorganize. And then diaphragm release. So diaphragm release is something that we teach in our Cranial 1 class too. And you can utilize, I call them the sandwich techniques we teach you for major transverse diaphragms, but you can utilize that sandwich technique for all your minor transverse diaphragms, which are every joint in your body. So any of you who might have been in your Cranial 1 class and they talk about Mary Ellen Clark, the diver who Dr. Upledger had on his table. She came in with a vertigo. He ended up down on her knee, and he's working on her knee. There's an article written about it. If you haven't taken Cranial 1 and you want to read about Mary Ellen Clark, you can pull up that article. And I've had Cranial 1 students come up to me, well, what was he doing down there? Because that's not your craniosacral system. He I'm guessing, I wasn't in the room at the time, but I'm guessing he was probably doing some direction of energy. He was probably doing a diaphragm release. He might've been doing a little bit of fascial glide, which is a different technique that we teach in our Cranial 2 class. But there's things that we can do in the periphery that can be really helpful. And again, they are all just helping the body to reorganize, right? Energy and remodel tissue. So we basically make the joint into a sandwich, one hand on one side, one hand on the other side. We compress with very light pressure, think grams. We talk about the weight of a nickel in our Cranial 1 classes. And we're just taking a little bit of the tension off that tissue, which allows it to work through its self-correction or reorganization process. We're going to follow any little bit of motion we might notice there. And we may notice changes in the tissue, which could include a softening of the tissue. Maybe we feel a little bit of heat and energetic release from the tissue. So lots of things that can happen there, but just know that this is something we teach to very young children. So it's really not hard, the direction of energy and just having their hands on, which kind of provides that diaphragm release. So I just have some examples of doing diaphragm release. This is a diaphragm release on a knee. Okay, so you make the knee into a sandwich, could be top to bottom, can be side to side. Okay, compressing with just think less than a nickel maybe, and offering energy through that system, either in or out from some universal energy source. Again, at an ankle, right, a sprained ankle. Okay, so just hand positions, giving you some thoughts. Now, obviously, if it's a smaller joint, you need to modify your hand position. So this is showing you what it might look like at one of the knuckle joints, right? Much smaller. And even a smaller joint at the AC joint at the shoulder. So showing you how even just with one hand, I can get my hand in position to do a little bit of a diaphragm, and I can offer energy through their system there as well. So just giving you some thoughts on what that might look like. So we're going to do a practice exercise, and I do realize I'm running a little longer than I anticipated. So we have about 5 minutes, and so we're going to take the next 5 minutes to do this practice exercise. What I would like for you to do is, if you have an acute injury, I was going to say fabulous, not fabulous, I'm sorry for you, but that gives you an opportunity to practice this on an acute injury. If you have something more chronic, that's fine too, because remember, these techniques work pretty much for anything. So an area maybe where you have pain, either acute or chronic pain, maybe an area of decreased mobility where you had an old injury. You can certainly try this on that particular area. And so I'm going to back up here, and we're going to say maybe it's your knee. So what we're going to do is lay your hands on the knee. First thing you want to do, actually I'm lying, I'm going to go forward. Here we go. First thing you want to do is lay your hand on that area. Just take a moment and see if you can perceive the cranial rhythm. Remember that it's a very subtle motion. At a shoulder, an elbow, a hand, and a knee, it's all going to be internal, external rotation. Extremely subtle internal, external rotation. So just take a moment. If you can perceive the cranial rhythm, that's great. If you can't, it may mean that there just isn't one. And that's possibly because of whatever injury process is going on there, whether it be acute, whether it be chronic. But it is something to notice. And you can actually, if you're curious, maybe palpate on the other extremity, the same joint, the same area, and see if you notice anything different there. So if you perceive the cranial rhythm, great. If you don't, that's an indication that there may be something going on there at that joint. Treating. So we can do a still point anywhere, and this is a more global treatment for anything that may be going on in the system. And this is a picture of doing a still point at the feet. Since we're probably doing this on ourselves as we're watching the presentation, again, the thighs are a great place. So you can take a moment, you can palpate your cranial rhythm at your thighs. If you were able to, if you have a knee, or you have a wrist or something it was that you were just palpating that's maybe an injured area, you can certainly try a more local still point. Just know that a still point is a still point, and every place in the body goes into still point at the same time, no matter where it is that you're doing it. So we're going to follow, if you're at your thighs, we're going to follow the cranial rhythm if you can begin to feel it. If you can't, what I would say is just give yourself very, very gentle pressure into internal rotation. Hold it there for just a minute. And then release and see if you can perceive the cranial rhythm now. Then you can check the specific joint, wherever it was that you were maybe having pain or swelling, and see if it feels any different. Is the pain different? Is the range of motion different with just the still point? It's possible, even if you weren't doing the still point on that joint. And then locally, wherever that joint is for you, if you can reach it comfortably, we can try diaphragm direction of energy directly over the joints. This is a more local treatment to help to facilitate, again, all of those changes we talked about at that area. So sandwich technique, one hand on the front or the back, one on the top, one on the bottom, it doesn't matter. However, it's the most comfortable and easiest for you. With your hands on that joint, you want to just give a very light compression. As you compress, again, you can offer energy in or out of that system as it may be asking. Keep yourself grounded. If you happen to notice any motion that starts to happen, any of that self-correction that may start to happen, you can follow that. You may feel tissue changes start to happen underneath your hand. You may feel softening of the tissue, maybe lengthening of the tissue, maybe heat release, or any sense of fluid flow even underneath your hands, especially if it's a swollen area. And then you can check to see, is there any sensation changes in that joint? Does it feel less painful? Do you notice more range of motion? Or if you are able to palpate the cranial rhythm, does that feel different? So indications that something there in the tissue has changed. Excellent. So I'm going to come out of my screen share because that is, I always think I'm going to be short. And then I don't turn out to be short. But that is all I have for you tonight.
That was terrific, Lisa.